is on flexible endoscopic surgery. What is the future? I'm going to talk on few aspects of third space endoscopy, how it's transiting from there to endoscopic full thickness dissection, how we are transiting from ERCP to US, and similarly artificial intelligence to robotic. But before I start, I'd like to acknowledge these pioneers in 1970 who, without the modern endoscope, without the modern technology, were responsible for the progress of gastrointestinal endoscopy as we see today. You'd recognize many of them. They've had the courage, the inspiration to work towards this goal. And right now, where we stand in J endoscopy is because of the firm base that these pioneers have laid. So let's start with third space endoscopy. Most of the progress is occurring here. Basically, in third space endoscopy, we look at the space between the muscularis propria and the mucosa, and then creating an artificial space followed by a flap valve mechanism where you can make a flap and then get into the space. We can do a lot of things. Now, in 2007, Pankaj described the technique in a canine model, and following this, I think in 2008, Harovini did the first poem case. It took a long time at that point, but now it's got standardized, and very often it just takes 15 to 20 minutes to do poem for achalasia cardia. The third space endoscopy spectrum has now increased not only to achalasia cardia, but to subepithelial tumors, refractory gastroparesis, diverticular, Hirschsprung's disease, nose fundoplication, and esophageal strictures. So all these are no longer a surgical disease because they can be treated endoscopically. Similarly, G-poem, I think, is an interesting concept in patients with gastroparesis, especially those after surgery. Sometimes with diabetes or idiopathic, where you can actually go submucosal in the greater curve of the stomach and split the pyloric muscle, giving quite dramatic results in some other patients. STER is another concept where you go in through the submucosal space, open it up, and then take tumors which are there, for example, neomyomas in the esophagus or disc-like tumors in the stomach, and these can be removed through this tunneling technique. And then the flap can be closed safely so that these patients then don't require an open surgery, can be discharged almost in 1 or 2 days. And the potential complications are extremely low. I think so. This is another major advance that occurred. All this is established, but I think we are now going further. In addition to doing all these, we can, for example, do Zenker's diverticulum, Z-poem, and so on. But we've moved further on in recent times. From poem, we have moved to poet, as you've seen, we have moved to Z-poems and Z-poems. But more interesting is the deeper layer dissections that are coming in. It used to be a standard EMR, ESD we're doing for these predominantly mucosal lesions. But now for subepithelial lesions, we can do what's called the EMD, endoscopic muscularis layer dissection, ESSD, endoscopic subserosal layer dissection, EFTR, endoscopic full thickness dissection. These are terminologies that are becoming very common in endoscopic practice. And you can, as we go around, you can see that these deeper layer dissections can be done very safely. And it's very important to remember these terminologies because they're going to become the future. Like we say ESD now, or poem now, EMD, ESSD, and EFTR are going to be very commonly used in future endoscopic terminology. For example, in a patient like this, where the tumor is predominantly in the subepithelial lesion with invasion beyond the muscularis mucosa, we can do an ESD, submucosal muscularis dissection and take out this tumor. But if the tumor is going predominantly into muscularis propria also, then we can do an endoscopic full thickness dissection, which can be done by freehand technique, where the tumor can be removed, or it can be done by EFTR devices which are now coming, which are attached to the endoscope with a cap and can be done quite easily without the need for a strong expertise in ESD. But all these advances have occurred because we also have better traction methods. How we can now prevent lumen collapse by putting in a balloon at the side. But more important, I think, have been advances in closure methods. This is the single most advanced, which has actually resulted in doing better endoscopic procedures. We can close these defects because of a variety of clips that are available, but also new techniques. I'll show some of this. Over-the-scope clips are commonly used for defects like this, which can be very easily closed, at least if they're less than 2 centimeters in size, by pulling into the cap and then closing the device. So now this has become very common in practice. After doing the dissection, if you find a full thickness dissection, this can be closed with this technology. The other technique is the E-lock technique, where we can create an O-ring. I'll show you more details of this later on, and put multiple clips to close this. So we have this king closure technique, which we use very common in our department, where we have different types of disposable loops, which can actually be kept on the area where you want to clip. This is a loop which can be actually released completely, and then the clipping is done. Let me show you an interesting video of how this is done. So if you have a patient like this who has a large defect which has to be closed while a dissection, we would then do put a loop initially, detach the loop, and then put multiple pressing sutures to. For example, you see here, we created a large defect here. After removing this tumor, subepithelial tumor to the POET technique, there remains a large defect which is almost full thickness, and this has to be closed. So to close this defect, we of course control all the bleeding areas, and then see the loop, that detachable loop which is kept in place. We then put clips around these detachable loops and then pull the loop together. This is a specialized loop which is available for this purpose. The loop is pulled together and all the clips come together. So this is a very useful technique that one should master when doing this procedure. Similarly, we can also do this technique where we do a central loop here to decrease the size of along with a small thread, and then close further. We can also do incisions on either side and then use this effective closure method. You can see the central thread technique very easy. We have a thread which is passed through the standard clips and then taken to the other side, and then with some tension you can pull it together. Some people also use rubber bands for this to get it together, and see, once the defect comes together, then it becomes very easy to clip it. So full thickness dissections are becoming very easy because of all these devices. But we are going to get better devices, and this is a recent Japanese stapling device which is going to be introduced soon in endoscopy, where a stapler is put to the end of the endoscope and you can just staple like a surgeon, and large openings can be closed with these techniques. So I think all these techniques have resulted in our ability to rethink about nodes. In 2003, we did the first human appendectomy, and that time it looked very strange. But now, with all these techniques that are available, I'm sure we can approach the peritoneal cavity through the stomach or rectum, do these procedures and secure a complete closure. This should not be a problem in future. So I think this is going to be the future of flexible surgical endoscopy that's going to come in, where many of these procedures, so-called surgical procedures, are going to be done by endoscopic physicians too. So this is something going to a reality. Now coming to another area, and this is the area where there is transition occurring. Traditionally, for patients with obstructive jaundice or those with CBD stones or pancreatic pathology, we're doing ERCP, endoscopic retrograde cholangiopancreatography, to go into the bile duct or pancreatic duct. And with the advent of cholangioscopes or pancreatoscopes, this is advanced further. But something is happening here. We are slowly transiting from ERCP to US, because US is now becoming much more easier. In fact, ERCP, which was at that time primitive, you can see Peter Carter in 1985 doing an ERCP with a scope which is attached to a camera hung from the ceiling. The view was not very good. The papilla could not be visualized well, yet these pioneers, as I told you earlier, did many difficult procedures and standardized them. So this is changing now. Even US had the same problem in 1989 when I went to train for US in Germany. These scopes were very large, the room was dark, the picture was very grainy, and it's not very encouraging. But slowly this has evolved. We now have extremely good scopes, very easy to use with a good resolution. So we are evolving now from diagnostic staging with the US to therapeutic procedures. And let me show you some of these that we're going to come in. We're going to do drainage of pancreatic fluid collections. Now it's solely done by US, never by endoscopy. Endoscopic gastrojejuostomy is now becoming rapidly a reality, in fact, competing with surgical gastrojejuostomy. US biliary drainages are replacing ERCP as a primary drainage for obstructed biliary system. US vascular interventions are being done, and even I think TIPS is now going to be done by endoscopic ultrasound. Similarly, US RFA for tumors in the stomach, tumors in the liver and in the pancreas. For patients with gastric varices, for example, we are now moved away from simple glue injection to putting in foil, but it's here that there's going to be a revolution. I think slowly over a period of next few years, we see less and less ERCP and more endoscopic ultrasound to actually drain this obstructed system because of less chance of pancreatitis and so on. But what is really very interesting and what is revolutionary is that endoscopic guided gastrojejuostomy. Two recent trials, one comparing with the duodenal stent and other comparing with the surgical gastrojejuostomy, have very clearly shown the superiority of endoscopic ultrasound guided GJ versus other conventional techniques. So I think this, in my opinion, is going to become the standard procedure in near future. Similarly, this is an example of a pancreatic net that we've been showing. You can see very clearly that this net is getting RFA'd by endoscopic ultrasound guided technique without the need for any surgery. We are now treated several patients with insulinoma like this without the need of going for more risky surgery. Now, from here we translate another area which is very interesting and which there's been a lot of buzz: artificial intelligence and of course robotics. So there's again a transition in this area. Artificial intelligence and robotics in future are going to be the way that endoscopy is going to be done. And I think this has come quite more rapidly than what we thought. When you talk about artificial intelligence, there are several terminologies that are important. Artificial intelligence is just algorithms that perform tasks that usually require human intelligence. So that's very simple. But in endoscopy, it's much more complex. We have to do what is called machine learning. That is, the machine has to be taught what to recognize when it sees some images. And part of this is deep learning or CNN, convoluted network technique, where polyps can be identified, characterized, and so on. So these terminologies are very important to learn: artificial intelligence, machine learning, deep learning, and CNN, convoluted neural networks. So once you come across these terminologies and understand them, you realize that AI has got a big role. For example, from simple unclear endoscopic views that can occur, incomplete probe techniques in examination, and lack of knowledge in recognizing lesions, all this can be made up by AI. And you can see that using AI now, it's commercially available. You can actually map out which part of the stomach, colon you are completely examined and which part you left out. Automatic photo capture is there. And these AIs can now detect polyps, for example, or stomach cancers, and then characterize these into what exactly is it: adenocarcinoma, is it neuroendocrine tumor, and so on. So this is the pathway that artificial intelligence is going to take in endoscopic techniques, and mainly it has been applied in three areas: colonic polyps, Barrett's, and cancers. And because colonic polyps and gastric cancers are more common, what we see in clinical practice, let's look at some of these very important papers that have been published. In the Eastern world, gastric cancer has been the focus, and there's been some very good Chinese studies which have looked at early gastric cancer detection and characterization by using artificial intelligence. And this is an EndoAngel, just come from Wuhan, where they have very clearly characterized this lesion based upon the various activities. And you can see the EndoAngel performance, which is sensitivity of almost 93%, very high sensitivity and specificity. So neural network, the so-called CNN I talked about, improves endoscopic detections of early gastric cancer. And this again has been shown in the study published from the Chinese group. There are now several studies which have been published, which are coming mainly from the Eastern world, which looked at identification of early gastric cancer using the CNN technique of artificial intelligence with a very high sensitivity and specificity, almost replacing the expert endoscopist. In colonoscopy, AI has two roles. One is polyp detection. You should not miss polyps. The ADR rate should improve. The second is polyp characterization, the so-called CADX. Now, polyp detection has now become standard of care, and there are many institutions all over the world which are routinely using AI in their systems. There are 3 commercially available artificial intelligence systems now, which have incorporated this into their endoscopy system so that you can increase the polyp detection rates. And of course, there are again many studies, and this is the first study in gut sometime back, which showed that the ADR are markedly increased when comparing routine colonoscopy along with computerized examination. You can see a very high degree of significance when you use this. So now any of these 3 systems that are commercially available can be used. And when you put it into your available endoscopy system, you'll find that they're quite effective and you can detect a higher incidence of polyps. Okay. So this was a large study from Alexander Repichow's unit, which looked at 700 patients randomized into CDE group, that is computerized detection group, artificial intelligence, and control group, which had only HT colonoscopy. And you can see here the adenoma detection rate was 54%, extremely high when you use the CDA group, of which non-neoplastic resection was 68%. Adenoma per colonoscopy was 1.7%. And look at when they didn't use artificial intelligence. The adenoma detection rate dropped from 54% to 40%. And of course, adenoma per colonoscopy dropped from 1.7 to 0.71. Very, very clearly showing that, of course, in this case, they used the Genius from Medtronics, very clearly showing that by using this technology, one can improve your polyp detection rates. And the meta-analysis of all the RCTs, because there are a lot of studies now coming in this area, has shown a 47% increase in ADR when we use this artificial intelligence computerized technology to detect polyp. Okay, we know that detection is extremely useful. What about characterization of the polyp? This is a more complex phenomenon because we have to do a lot of machine learning, a lot of CNN before the machine can actually characterize and say whether you're dealing with the adenomatous polyp, high-grade dysplasia, carcinoma, and so on. In fact, this is the EndoBrain from Olympus company, which is being demonstrated here by Professor Kudo in one of our workshops. And you can see clearly that using EndoBrain, which automatically characterize the lesion, you can say the neoplastic lesion with 87% probability here. We have been using EndoBrain and published in this area. We found in our own unit that EndoBrain has a sensitivity specificity of nearing 90% in these cases. So I think soon you don't require an expert endoscopist to look at these lesions. The novice can use EndoBrain to come to a conclusion to know which lesions can carry, which lesions are neoplastic, which are not. What we have still not achieved is a typical JNet classification. So for example, if JNet 2B, is more difficult, these cases we have to think whether ESDs has to be done or surgery. These are the gray areas, and I'm sure with more research in this area, this will prove this hard. So this is again a large series which looked at endoscopic computer diagnosis. And the feeling is that maybe over a period of time, we can even discard the pathology. So now come to robotics and endoscopy. This is the interesting area. It is developing a little slowly because of the complexity of doing a flexible endoscopy robotics. Da Vinci system in surgery is a rigid system, has been there for many years, is easy to use, but flexible endoscopy is much more difficult because of the flexible nature and trying to put robotics to the end of this. So which part of the endoscopy can improve new technologies? All the parts, image processing, steering the endoscope, all can do with this. And in fact, I think here we're coming to integration of artificial intelligence with robotics to make it much more easier. For example, if you want to do an ESD, just imagine you have a knife on your head and trying to compare to using two hands, which is a standard technique to do these cases. And this is the report of the first robotic endoscopic surgery in the world, which was done in our unit in 2011, published in 2012, where we used the master slave technique, where you can see that I'm actually just holding the endoscope. My colleague, Dr. Pradeep, is doing a large ESD. We're taking about 15-20 minutes for even large cases like this because of the ability to use traction and then, of course, close the lesion, and sometimes even with suturing now. The new endo master slave technology is coming in this fashion, is taken up by a company which is going to come out soon with the commercial product. We have, of course, examples coming from laparoscopy, which has used both 3D laparoscopy, robot-assisted surgery. These technologies have been converted into flexible endoscopy. It's going to take more time, but eventually, in my opinion, in about 5 to 6 years' time, some of these technologies are going to be of commercial use. And of course, going further, nanorobot is a nanorobot technology is being used in, again, surgery and urology. Gastroenterologists are going to get it, where self-assembling robotic small devices, nanorobots, are going to put into the lumen and then they assemble again and then start doing that. But this, of course, is some time away. So the future in AI endoluminal robotics are better diagnostic and therapeutics. Endomaster slave system is actually now completed the clinical trial. There's going to be automation in endoscopic robots, and finally, future is going to be nano robotics. And finally, coming to luminal, which is going to be again some drastic advances that have occurred in this area. Endobariatric sleeve gastroplasty is competing with laparoscopic sleeve gastrectomy, and I think results are equal with less morbidity and mortality. Similarly, I think metabolic endoscopy with the duodenal resurfacing is another major area that we should look into carefully. Early studies seem to suggest by using this technique of ablating the duodenal mucosa with thermal hydrotherapy, we're able to cause new neuroendocrine cells to come into the duodenal mucosa and then decrease the insulin resistant factor being secreted from this area, resulting in better metabolic control. Again, very interesting data coming from several units showing that even if you damage the duodenal mucosa, nothing happens. The new mucosa comes in 3 months, but endocrine cells are not there. And this is the balloon, the recent balloon that's being used in this technique. And you can see that by using these techniques, we not only decrease the A1Cs, diabetic control, but improve liver functions, probably reverse NASH, and of course, decrease the oxidant injury in the body. Again, very, very exciting data, which over the next 3 or 4 years are going to tell us whether this can become the standard of care in our patients. Single-use duodenoscopes, again, are we going to completely go into single-use endoscopes, upper GI, colon? Duodenoscopes in some institutions now, we use this in our institute. I think there is a place for this, and if the price comes down to less than, say, $200 for endoscope, people would prefer to use this. And I think this is again going to be something which will come in the future. You can see very clearly how very large lesions can be now completely cleared with this. And you can see that after the procedure is over, we just dispose this off in a waste paper basket. We never think of it with a conventional endoscope. Another area that we have conquered now with the small bowel, it used to be an area which was of deep concern, which was difficult to get, but with the advent of spiral enteroscopy, we are now doing pan enteroscopies in 90% of our cases in a very short period of time. So pan enteroscopy has become a reality. Struggling with these balloon enteroscopes and all is no longer there. Having doubts the capsule endoscopy is going on, is off now. So its spiral enteroscopy is going to dominate, and last series that we published recently showing its utility. We also seen that when comparing spiral with single balloon enteroscopy in a recent article that we published, we showed that spiral has more an enteroscopic approach more often with less fatigue to the endoscopy. So these are going to be featured. Another device which I just wanted to highlight here is devices like this which are going to come up. The Gerdex device for full thickness stapling device for patients with reflux. You can actually use this to create a full thickness stapling, just like a surgical stapling. And a recent article that we published in Gut showed that you can not only improve the quality of life with this, but in 70% of the patients over 1 year period, we could completely take them off PPS. So I think this is something, again, exciting new news that's coming in the future. But it's important to remember that all these things would mean that better training in endoscopy is required. We have to transit from training from regular way to much better training centers. This is our lab at the AAG hospitals where we use this high-tech lab for training a numerous amount of gastroenterologists, both in suture techniques, closure techniques, in robotic techniques, and so on. So this is very important for gastroenterology or GI endoscopy to progress and further. And again, all over the world, you see these labs coming up much more often. Of course, as we progress in gastrointestinal endoscopy, we also recognize that these disruptive technologies are breaking the barriers between surgeons and physicians, so that we are no longer recognized as physicians, but as gastrointestinal endoscopists doing surgeries or physicians doing surgeries. But I think it's again important to remember that all this can be done only if there's a teamwork. If you have different team members, endoscopy has become so specialized, subspecialized, that you have third space endoscopies, pancreatic biliary endoscopies, luminal endoscopies, and so on. And this is what is going to happen in the future. And for this, require a good team. At the AAG hospitals in Hyderabad, we have this fantastic team and they're able to create this large endoscopy space. Thank you very much for your attention. I'm looking forward for the live demonstrations.
Thank you very much, Dr. Reddy. And by this recorded lecture, so we will conclude our session. And I want now to ask everybody for the live endoscopy transmission by Dr. Reddy.